So pancreatic adenocarcinoma, as we know, when we hear adenocarcinoma, both the tumors which starts with the letter A, adenoma and adenocarcinoma, they are exocrine. Okay, endocrine does not have any tumor with the name A. So adenoma and adenocarcinoma, and we know if you have any tumor or anything in the pancreas, it's mostly malignant, like 90% of the people, it's malignant. Okay, it's cancerous. So pancreatic adenocarcinoma, we're talking about exocrine and malignancy. So carcinoma of the pancreas is increasing in incidence, like most people are having it nowadays. And what you did not know is it affects the boys more, the males more than females. So the age is like from between 55 years old to 70 years of age. In between this period, you can have pancreatic adenocarcinoma. And it is not easily found out. It's not easy to diagnose. So the prognosis is poor. The 5-year survival rate is just about 5%. So it's really unlucky. You can't even find out and you even die. So let's know what exactly causes it. Like the etiology of pancreatic adenocarcinoma. The exact etiology is unknown. We don't know. The factors that probably increase the risk of having this cancer in the pancreas, they include smoking, which is the culprit in anything and everything. Smoking. And maybe obesity, chronic pancreatitis. If you have pancreatitis for a long time, you might develop adenocarcinoma, and also diabetes. Who knew? Did you know that diabetes could cause pancreatic adenocarcinoma? So what's the pathology of pancreatic adenocarcinoma? So in the pathology, we will take it in a little bit detail, still briefly, gross picture and microscopic picture. So in the gross picture, we will see that the growth is infiltrating, hard and irregular, just as you would expect to find in any kind of cancer. Infiltrating, hard and irregular. 60% of the lesions are situated in the head of the pancreas. We know since a very long time, and we keep on hearing that cancer head of the pancreas, cancer like that. So it's in the head. The remainder is in the body and tail. So most of the lesions are situated in the head, not like the rest of the body and tail are spared. No, it's all over, but most of the lesions are in the head. So of the head tumors, 2/3 are in head proper, and 1/3 is periampullary carcinoma. Periampullary carcinoma, right? The latter arises either from the ampulla of Vater, the duodenal papillae, or the lower end of the common bile duct. So 2/3 of the tumors are found in the pancreatic head, right, pancreas head, and then 1/3 you will see in the periampullary area, and then that arises from the ampulla of Vater. So we know it's not exactly located in a specific place. So it arises from ampulla of Vater too, and also the duodenal papilla, so covering that as well, and also the lower end of the common bile duct. Lower end of the common bile duct, this word is there everywhere. It's always the lower end of the common bile duct where the problem mostly is found. So let's talk about microscopic picture of pancreatic adenocarcinoma. What will you see close up? So the tumor is an adenocarcinoma. It comes from ductal system. So yeah, you see it's about ducts. It comes from the ductal system with variable degrees of differentiation. Cyst adenocarcinoma is very rare. You won't find it, cyst adenocarcinoma. We're not talking about cyst adenocarcinoma anyway. We're talking about ductal system and adenocarcinoma here. So spread. Where do you think it spreads? It has 4 types of spread. Direct lymphatic blood, and also another one which is transperitoneal. Right? Direct, the common bile duct is infiltrated early in the course of pancreatic head cancer. As we said, it's about ductal system. And also we said it is not localized to a single area. So common bile duct is infiltrated early in the course of pancreatic head cancer, producing obstructive jaundice. So it's a duct, and so when it's infiltrated, you will see obstruction, and hence you will see jaundice. The duodenum, alright, the portal vein, a vein, and inferior vena cava may also be invaded. So see, the veins are affected. Portal vein and inferior vena cava. We know the duodenum, of course, we said it before as well. That duodenal papilla is also affected. So lymphatic spread is to adjacent lymph nodes and to nodes in the portal hepatis. Porta hepatis. You see portal vein, porta hepatis. Portal vein, direct spread. Porta hepatis, lymphatic spread. The bloodstream spread is primarily to the liver. Okay, so the liver is now unsafe. If it spreads through blood, it goes to the liver. And transperitoneal spread with peritoneal seeding and ascites.